o'clock or 8 o'clock in some areas, 7 o'clock, 10 o'clock, wherever you are, we're starting the program. Welcome, good morning. This is the first Zoom family meeting for the Myocarditis Foundation. For some of you, it's earlier than others, and I hope that you all have your beverage of choice as you listen to our esteemed Foundation cardiologists, Dr. Jack Price and Dr. Leslie Cooper. Many of you have spoken with me at some point, but we have not officially met. I am Jen Ramori, the Executive Director for the Myocarditis Foundation. I'm the spouse of a viral myocarditis survivor who had his transplant 14 years ago this November. He has been with the Myocarditis Foundation and is on the call today. He's been with the foundation since 2007, which is shortly after the foundation was founded. And as some of you may know, this is quite different than our previous family meetings. You may have heard me say that this is a first for us earlier, if you were on the call. We're hopefully going to be doing more of these. We do understand that meeting people in person means an awful lot to the patients and families who have been through this journey, but until the world allows us to meet again in person, this is the best that we can do, and I hope that it will help you all with speaking with the doctors. We have 26 families participating in the call today, consisting of a mixture of viral myocarditis and giant cell survivors, some with transplants, some people who have had loved ones pass due to the disease, and viral myocarditis survivors and people who have passed as well. A few of you have been to our previous meetings. For many of you, this is our first introduction to us. We welcome you to this family of sorts, one that really no one wants to be a part of, but you'll have a better idea of who we are and what we do and where you can come for support. A few things to remind everybody before we start. We have muted everyone as you joined. If you have any additional questions, please wait until the speakers have finished with their talks, or if it's a pediatric question, please go to the chat room and we will try and answer it for you before Dr. Price leaves. As we have limited time with the doctors and we have so many questions that have been submitted, we hope that we can answer as many as possible. Please leave your screens on the mute setting. We have the chat screen open where you can submit questions. And now I'd like to introduce our esteemed cardiologists who are on our board of directors. Dr. Jack Price, who is a pediatric cardiologist and heart failure specialist at Texas Children's Hospital. He's been with the foundation since 2014. He started and was the director of the first ever pediatric heart failure ICU, where he has seen many cases of myocarditis that come to him from all over the world and the country. Dr. Leslie Cooper, an adult cardiologist researcher who specializes in myocarditis, is world renowned for his research in giant cell. He is the chair of the Enterprise Department of Cardiovascular Medicine for the Mayo Clinic. He is co-founder of the Myocarditis Foundation. And now I will be opening up the meeting to Dr. Price and Dr. Cooper. Welcome, everybody.
Thank you.
Great, thanks, Jen. Great introduction, and looks like a nice crowd today. Wasn't sure what our turnout would be like, but this is impressive. And I'm excited to see this, and hopefully we can answer some of the questions that have been weighing on your minds and give you a little bit more information. I'm going to start off by answering some of the pediatric questions that have been submitted. And I'll start with this one that's come up. The question is sepsis with myocarditis a common comorbidity? Can one cause another? Is there a recommended course of treatment for when the two occur? And is there or could there be a genetic component that predisposes a person to myocarditis? So first of all, I guess we can explain what sepsis is. Sepsis is commonly thought of as the body's response to an overwhelming infection. It's typically thought of as being potentially life-threatening. We usually think of sepsis occurring in patients who have bacterial infections. However, we also will use the term viral sepsis in patients who are very ill, unstable, with known viral infections, although that seems to be a little bit less common than bacterial sepsis. What happens in sepsis is the body responds in such a way that to the infection that blood pressure is affected, blood pressure becomes lowered, breathing becomes labored and increased respiratory rate, more difficult for the patient to breathe. The heart rate may go up quite a bit. Sometimes in these situations, the infection or sepsis can be overwhelming to the whole body, including other organ systems besides the heart. So, for example, you may have a negative impact on the liver, causing liver injury. You may even have abnormal liver function during sepsis. The same is true for the kidney. The kidney can be affected and can sometimes shut down. So sepsis is just sort of the body's response to an overwhelming, life-threatening infection. And the next question is, can one cause another? So I guess the question is, can myocarditis cause sepsis, or can sepsis cause myocarditis? This is an interesting question, and there's a lot of nuance to this question. So I guess my answer is partially yes. We know that patients who have overwhelming bacterial infections, for example, part of the body's response to that is to release certain enzymes and proteins and chemicals in the inflammatory response, and those chemicals themselves can cause depression of heart function, maybe some inflammation as well, but it's not the same thing as a primary viral myocarditis. So it's a little bit different. It's an abnormal heart function occurring as a result of a bacterial infection. And can myocarditis cause sepsis? Well, we know that the organisms that can cause myocarditis certainly can cause sepsis and potentially life-threatening infections that affect the whole body. Is there a recommended course of treatment for when the two occur? So, I think, a lot of this depends on what is the source of the sepsis. If this is a bacterial infection, you can identify the bacteria with cultures, blood cultures, for example. And if you know the organism that you're dealing with, you can tailor your antibiotic therapy to treat that particular organism. It's a little bit more difficult in situations of viral myocarditis, where our ability to treat or kill a virus is a little bit more restricted. We don't have the therapies for that in the same way that we do for bacterial infections. So that is still a challenge for us on the viral side. Is there or could there be a genetic component that predisposes a person to myocarditis? This one, I think we're learning a lot more about, and I wish one of our other colleagues were able to help with this question, because I think we're still in the process of learning a lot about this. Is there a genetic mutation that causes myocarditis? No, we're not know of a mutation like that, but we do know that everybody is different in how they're made up, including with their ability to fight off an infection. And so there are subtle differences from person to person in their ability to fight infection that makes us unique and different from others. But the uniqueness may be there may be more similarity within a particular family. And Les, feel free to weigh in if you have a little bit more insight on this. But at least on the pediatric side, this is very rare. Muted. I think he's muted. I think Les is muted.
There you go. Thank you, Jen. Thank you. So, Jack, that's a great set of questions, and I totally agree with your answers. In terms of the genetics, there's an evolving, emerging literature on proteins called desmosomal proteins and genes responsible for these, which has historically been associated with right ventricular cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy. These are now coming out in the last 5 years as being associated with some cases of recurrent myocarditis or arrhythmogenic recurrent cardiomyopathy, which is, again, it's a bit, the language here is confusing perhaps, but basically people who have recurrent episodes of myocarditis, and that runs in families. A few of those families have been studied and shown to have these desmosomal gene mutations. So that's an emerging literature. There are about 8 papers that have come out since 2015, and it's not the majority by all means, and still the risk of recurrent myocarditis is still on that order of 10% or less, depending on how people present. But it's but a fraction of that is going to be genetic. But Jack, you're absolutely right. As far as I know, there are no major genes or any indication for general genetic testing in this setting.
Okay. Les, you want to do an adult question? And we can kind of go back and forth?
Absolutely. So thanks everyone. We have several dozen questions here and that have been sent in already, and we'll go back and forth. Jack and I are going to go back and forth and answer as many as we can, and then group them into sections. Because Jack's here just for the first hour, we're going to try and get through the PEDS questions in that hour. He'll give much better answers than I will. The 4 groups are pediatric myocarditis associated with COVID-19. Then within lymphocytic myocarditis, diagnosis, prognosis, and treatment. And finally, there are 8 questions on giant cell myocarditis. I was going to save the giant cells for the end and focus on them. But let's start with COVID-19. Obviously, it's a huge issue for the sports teams in this country, both professional and collegiate athletes and high school athletes. And we have 10 questions here that I've listed. The first is, are the symptoms of COVID-19 the same as myocarditis or different? Most commonly, COVID-19 presents with a fever and cough, but you can have chest pain. And in young people, you can have a COVID-19 associated myocarditis. It's quite uncommon, as opposed to the more common older patient in their 50s or 60s or 70s who may have a primary pulmonary presentation. So the answer to that question is that you look for myocarditis in the setting of COVID the same as you would in other viruses with a troponin, an EKG, sometimes an echocardiogram. But there isn't a specific test other than a heart biopsy, which we reserve for people who are quite sick. Thoughts on that, Jack?
Yeah, I agree, and I think it's hard to estimate what the true incidence of myocarditis is with this virus. We've talked about it and how a lot of people are not getting traditional imaging or diagnostic methods when they come in with COVID-19 to rule out myocarditis, even in the presence of abnormal heart function. I know I've seen it in my own institution where we've not performed a cardiac MRI, whereas normally I think we would have in a patient who comes in with new onset heart failure in order to rule out myocarditis. So we may be missing some patients that way. But again, kind of alluding to what we were talking about in the last question, just overwhelming illness, whole body inflammation and illness can result in abnormal heart function secondarily, instead of being the first thing that's affected. So it's kind of hard to tease that out.
For sure. And I'd like to make a distinction that'll segue back into the pediatric questions. One is that the typical patient who's hospitalized in the intensive care unit with COVID-19 is older. These are people maybe 70 or older with diabetes or hypertension, maybe some pre-existing coronary disease, and they are often very sick. They're often on a ventilator, and they have a need for intravenous medicines that are needed to support blood pressure. that's that most of the literature that's been published early on from China, New York, is in that older population. The more recent literature on the younger patients where myocarditis or cardiomyopathy is much less common is a very different population. And as Jack was saying, because we're concerned about spreading COVID in the hospital, there hasn't been a large appetite for doing MRIs acutely because you expose the MRI team to COVID potentially, and there's a need for a terminal clean of the MRI room. So that has often been deferred for a couple of weeks until after the infectious risk is gone. So I agree, there's less advanced imaging because of the risk of infection, and when we do get the diagnosis, it's based upon MRI, which is different than heart biopsy. But that brings us to the kids. I was going to say, what do you think, Jack, about this emerging literature on young people, both children and young adults now, who have this inflammatory syndrome, maybe something like a Kawasaki's disease, sometimes with coronary artery aneurysms?
Yeah, we're learning more and more about this, and it was not on our radar in the first few months of the pandemic, and then we began to see patients several weeks after their initial exposure or infection coming in with an inflammatory response, sort of a whole body response that's in many ways mimics something called Kawasaki disease, which is a disorder that's not completely understood about its etiology, but presents with things like swelling of hands and feet and swollen lymph glands and red face and some laboratory tests that are abnormal. And we know that the vast majority of kids who develop an infection with coronavirus do very well. In fact, it's thought that about 20% of them are completely asymptomatic. So a very small proportion of those patients ever end up being hospitalized, and even a smaller number require hospitalization in an ICU. Those who develop this severe inflammatory response very often, in fact, the majority of our patients that we've seen have an underlying condition to begin with. Some of them have underlying cardiac disease. Some of them, have diabetes or have had a history of cancer and have required cancer therapies. And some of those patients become very, very ill. We've had several patients that we've had to support on ECMO or some form of artificial heart support. Thankfully, that has been temporary. The good news in those patients is that the vast majority of them recover nearly completely for most of them. And even the sickest ones, we've been able to get off life support, and we've seen a pretty quick rebound and recovery in their heart function. And it's still unclear where we're headed for these patients in the long term. We will continue to follow these patients long term. I think we'll be getting additional imaging as an outpatient for these patients. But the good news is, despite the severity of their illness, the recovery seems to be very reassuring, and it occurs for most of our patients.
Absolutely, it's really remarkable how young people can rebound back from even very severe myocarditis. You can see essentially full recovery if you can bridge through that acute episode. And there will be down the road some questions on mechanical circulatory support we'll come back to. There are 5 questions on for COVID-19 I'll take together. 4 of them are on vaccines. Questions about should they take in the future vaccine when it's available, should myocarditis patients use it, what is the, and then what about precautions for myocarditis patients with COVID? I'll take those all, those are 5 questions I'll just take together and say that we don't know yet what the vaccine will be, if it's going to be these antibodies or other kind of immunogenic proteins that will be given to protect you from the viruses. In general, people who have had myocarditis in the past are perfectly able to get vaccines. So there isn't in general any prohibition. Having said that, I don't know what the vaccines will be. And so it is important for you to check whoever if you're considering getting the vaccine, talk to your physician and make sure that in that specific instance there isn't any contraindication. With respect to masks and hand washing, the question, yes, like all of us, if you've had myocarditis, if you're going to be out in public, wearing a mask for sure, and frequent hand washing and social distancing are important. And there isn't a specific myocarditis-specific guideline, but the same guidelines that we have for all of us are very important to follow. Those are 5 questions together, Jack. Any thoughts?
No, I agree with you, and I'm not sure where we're headed, with this vaccine still. But once the FDA approves one, I'm going to be first in line. Yeah.
Right. Let me say there are the other questions on COVID-19 are I think fell broadly into those categories about diagnosis and management. We're now going into a fairly large section on myocarditis in general. These are, I would say, there's one on lupus and myocarditis we could take first. It's a specific question about an 18-year-old, but I'm going to answer generally. And because this is right on the edge of pediatrics, Jack, maybe we should take it together. There's a question about if you have had a positive ANA and recurrent myopericarditis with elevated troponin and a clinical syndrome, but is there a specific management or evaluation? Do we recommend in general, not specifically any immunosuppression or further workup for the possible lupus-associated myocarditis in an 18-year-old generally? Thoughts about connective tissue disease-associated myocarditis in general?
Yeah, that's, at least on the pediatric side, that's rare. That's very rare. But we know that patients with lupus can have cardiac involvement and some degree of cardiac inflammation. So when I think of chronic recurrent myopericarditis, it's in a different sort of category from patients who have lupus. And so I have certainly treated patients with chronic myocarditis or recurrent myopericarditis with things like steroids, which technically would fall into the category of an immunosuppressant agent. I've never employed anything kind of stronger than that as what's being considered here. I don't think it's unreasonable to consider something like that in a situation, that seems to be pretty recurrent and possibly, debilitating depending on the patient's symptoms. That's a lot of troponin leak, and so I would guess that patient's experiencing a lot of chest pain associated with it. So I think we're getting way out onto the periphery of our experience in cases like this. And I know there was recently sort of a case series of patients, I think with lupus, who were treated with, what was it they were being treated with in this particular question? Again, last.
The question was corticosteroids and IVIG, possibly CellCept.
CellCept, okay. Yeah, I think there was a recent case series, a very small case series of patients with lupus who were treated with CellCept, who had myopericarditis, and it wasn't powered for survival or anything like that, but I think they looked at cardiac function, which improved. These are a very small proportion of patients, at least on the pediatric side of things. Maybe you have more experience on the adult side, and so this would be something that I would want to partner closely with my rheumatology colleagues in a patient who's affected like this, just to make sure that we're treating the right thing and not missing something else. So I don't know, Les. That's probably not a very satisfying answer, I'm afraid, but.
Well, I think for the general group, because most of the people listening on this video call today may be interested in general in myocarditis. They've either had a family member affected or they've been affected themselves. And I'd say when any one of us, particularly in the adult world, evaluate a new onset myocarditis, we always ask, is it due to, what is it caused by? And one of the causes of myocarditis and pericarditis are connective tissue diseases like arthritis or lupus. Again, as you get older and in different populations, there may be higher rates than in the pediatric group. And usually the diagnosis requires a good physical examination, some blood tests, and sometimes there's some imaging like joint imaging. And we always get our rheumatology colleagues involved to help us with those diagnoses when we suspect that there is an underlying or contributing systemic inflammatory disease like lupus. So without, again, we're not here to give specific advice for any one person, but I would say in general, you have to weigh the benefits, the potential benefits against the harms and the potential harms of the side effects of immunosuppression, which include drug-specific side effects as well as cancer, long-term immunosuppression, and opportunistic infections. So it's a tricky balance. We always try to use the safest medicines first. So things like colchicine, which is not a very powerful immunosuppressant, or ibuprofen, a non-steroidal anti-inflammatory agent for pericarditis, if might be safer medicines, and then you ramp up slowly through the corticosteroids and other medicines where you get more side effects with chronic therapy. So those are just kind of principles there, and I wish you the very best if you're on the phone call. So were there any other pediatric questions we wanted to address in the first hour?
Yeah, I have a few more here, Les, if we're okay to switch over.
Sure.
Let's see. Okay, here's another set of questions. The first question is, regarding exercise with myocarditis. I know that exercise and physical activity play a part in myocarditis. I would like to know if there's a certain time frame that one should limit their physical activity after having a virus. I know that it's hard to keep children from being active, but is there a time period that children should skip their sports activities or just try to take it easy? And typically what we're recommending in pediatrics, and I think this is probably true on the adult side as well, is to limit activity for the first 6 months after the diagnosis. During this time, we restrict our kids from participating in competitive sports. That would include PE classes. And you're right, it can be very difficult to do that. I think just normal routine sort of activities at home are acceptable, and we tell our patients that. And that includes things like, recreational, riding your bike, or maybe shooting some baskets in the backyard. That sort of thing is perfectly fine. But when you start exerting yourself, participating in a team, having a coach and peers who are pushing you, then that would be off limits for us until we're able to reevaluate the patient 6 months after the initial disease process. And it varies from patient to patient also, depending on the severity of the illness, what kind of heart function that recovers, the degree of injury that we see, possibly on an MRI, whether or not the patient is having abnormal heart rhythms during the recovery phase. For some patients that we're particularly concerned about, we'll have them run on the treadmill and do an exercise stress test where they're hooked up to a bunch of monitors, monitoring their heart activity and electrical activity before we give them clearance. So there is some variability in there, but the standard recommendation is no activity during the first 6 months after the infection. The second question is, I have a son with a PFO. And for those of you who don't know, a PFO is short for patent foramen ovale, a fancy Latin term for a little hole in the heart, in the wall separating the upper chambers of the heart. We all have one of those holes when we're growing inside the uterus as a fetus. It's necessary for life at that phase. However, after birth, that hole begins to close. And for most people, it goes away completely. But for probably 20 or 25% of the population, it persists. And the question is, I have a son with a PFO that we discovered shortly after our daughter passed away. I was told that a PFO is clinically insignificant. Is there any information regarding PFOs and people with them being more susceptible to myocarditis? And the quick answer is no. There's no association, no known association between myocarditis and having a PFO. Like I said, we all have PFOs at some point during our existence, and for the majority, those close after birth. I understand that myocarditis is not hereditary, but I have heard of members of the same family having myocarditis. Is there any new information? I think we touched on this on a previous question, and I think Les kind of gave some good background on that previously. So maybe we can skip that one and move on to another one so we can get everybody's questions answered. Is there anything we, as family members of myocarditis victims, can do to encourage our local hospital to become more familiar with pediatric myocarditis or myocarditis in general? My husband took our daughter to the local hospital, and they had no idea what was going on with our daughter. They initially thought she was diabetic because their blood sugar was high. Other than that, I really don't think they knew what they were up against. I've wondered several times that if they had more knowledge of the disease, if my daughter would still be alive today. Well, I'm very sorry for your loss to begin with. That's a tragedy. And, you know, this is something really important to me. You know, as a physician, you know, and a board member of this foundation, you know, I have a passion for educating people about this disease process, not only the public, but in general, but physicians also, and nurses, nurse practitioners. And Jen has done a fantastic job with this as well. She's put a lot of blood, sweat, and tears into educating physicians and other personnel within hospitals and clinics. She's gone to various different conferences and done that. I'm speaking at a national nurse practitioner conference next month. But you're right. This is a tragedy because, you know, for example, a colleague of mine, we put together a set of patients that was published. The data were published in one of the larger pediatric journals, not just pediatric cardiology, but pediatrics in general, describing how often this happens. It's about 50% of the time a child with new onset heart failure comes to the attention of a caregiver, either an ER or a clinic visit, with symptoms from their myocarditis or their heart failure, and they're misdiagnosed as having something other than heart failure. And for many patients, this can mean a lot of unnecessary testing, invasive testing, procedures, and treatments, you know, that are completely unrelated. It can cause frustration, clearly, obviously, for patients and their family members, but it's also, I think, causes a lot of frustration for the caregivers. You know, they're trying to do their best, I think, and we're dealing with a rare disorder that, at least in pediatrics, mimics other common, frequent, you know, pediatric disease processes. And it can be very difficult to diagnose, plus the fact that we don't have a specific diagnostic tool just for myocarditis. And so you have to put the whole picture together. You know, unfortunately, the whole picture doesn't come together for some of our patients only until later in the process. And my commitment as a member of this foundation is to do the best that I can for educating the public and my peers. One of the sort of benefits of this whole pandemic has been an increased awareness of myocarditis. Obviously, it's related to COVID, but I think even more in general, we're hearing more about myocarditis. I think our website has probably seen more activity related to this more recently. I know that at scientific meetings I go to, now I'm hearing more about myocarditis. So I think that's going to be one of the sort of lasting benefits of this pandemic that we've gone through, is raise awareness. And I think that's the best that we can do right now. I don't know, Les, do you have anything more to add in a sad situation like that?
No, it does take us to a series of questions that have come through, were asked online about diagnosis. And Jack, you're absolutely right. We don't have a specific test for myocarditis. We get to it often excluding in the adult population coronary artery disease and other forms of valvular heart disease that are more common. But in the pediatric group, in the young adults, it can be very insidious. And kids and young adults have a lot of functional reserve capacity. They can look pretty good till they're very, very sick, and then hemodynamic crash. And so you don't often get a lot of warning. You know, it can often be a very sudden or fulminant is the term we use, presentation when they do reach the edge of their ability to compensate hemodynamically from a blood pressure and heart rate standpoint. So it is our message to the emergency room doctors, the primary care doctors, to pediatricians, to the family and internal medicine doctors is to be alert. Always remember that in the young person who does have a chest pain syndrome or a shortness of breath that is out of proportion to what you would expect for a normal flu-like or illness, to always listen to those lungs, listen to the heart, and consider getting a troponin or an EKG if there's a question about whether there's heart involvement. Fortunately, as Jack said, this is an uncommon to rare event, but when it does happen, you do have to be mindful for arrhythmias and heart block and be able to manage that effectively in the right kind of medical environment. You know? Actually, there is a series of questions on management as well, which I think is some of which are regarding young individuals here. There's one on pregnancy, and the question is, what research has been done regarding pregnancy following myocarditis? And this is I think Jack and I can both address this from different perspectives. From the standpoint of recovered heart failure, we don't have a specific literature, but there's a fair amount of literature on peripartum cardiomyopathy, women who develop heart failure, a low heart pump function during pregnancy, toward the last trimester or shortly after delivery, and then recover. So not all of that is due to myocarditis. A minority of it is, but in that setting, we know that if you're fully recovered, there is a small risk, there is a real risk of recurrence, but the risk of death from a second pregnancy is relatively low, and it's a shared decision making in that setting. And so I would say in women who have had pregnancy or who are considering pregnancy after myocarditis, if they never had a decrease in heart function, if it was just chest pain that occurred, say, 5 years ago, and the heart function was always normal, I do not see any contraindication to pregnancy. If it was heart failure with a low ejection fraction, low heart function, and then recovered, that's shared decision-making, recognizing that the data we're citing are not specific to myocarditis. They're heart failure data, recovery heart failure data. But it's a shared decision. What do you think, Jack?
Yeah, I guess my perspective is maybe on the other end, on the baby side, of pregnancy. It's known that you can have an intrauterine infection that affects the baby, including the heart. And so we have had, in my experience, several newborns who, after delivery, or even before delivery, we find that they're suffering with abnormal heart function. Sometimes they have to be delivered prematurely because of, non-reassuring fetal heart tones or something else about the pregnancy that is problematic. And so we'll deliver those babies and treat them. There are certain viruses that are known to occur specifically during that time period, one of them being CMV or cytomegalovirus, which can have a deadly impact on our patients. And so that's, I guess, when we talk about pregnancy, that's one side of it that we have to consider on the pediatric end. And that's not necessarily mothers with myocarditis, but mothers who have an infection that is transmitted to the baby and impacts with heart failure.
And this, while we're on the subject of infants, another question came in. What is the myocarditis numbers and breakdown in the United States? Is the infection rate in the US slowing down? I do not have myocarditis specific data for the US, but when you combine myocarditis with cardiomyopathy, which we do on a global scale, because for most of the world, Africa and Asia, they don't have MRIs and biopsies, and so it's very hard to distinguish acute cardiomyopathy from one of the specific causes, which is myocarditis. Usually you need a biopsy or an MRI to make that specific diagnosis. So if you look at those together, in the first year of life, in neonatal to year 1, there's a relatively high rate of cardiomyopathy myocarditis as a fraction of all babies. And then it drops down in childhood to about 14 to 15. And in the global burden of disease data, it's actually broken down into 10 to 15, 10 to 14.9, and then 15 to 19 is the next age block. And then that's where it goes up. When the hormones kick in puberty, males tend to have a higher rate than females, and that pattern stays true into 20s and 30s. But in terms of rate trends, there's a small decrease. There's a paper that we have at a journal called the Journal of the American College of Cardiology that's coming out in about a month and a half, which describes the 2019 data and the trends. And there is a small decrease in both men and women in myocarditis and cardiomyopathy, mostly in the past few years, with actually an increase in other cardiomyopathy, which is a kind of a category we use when we can't define the cause. And so it may be a coding issue that changed the frequency, but it is going to show a small decrease over the past 25 years in the US and globally. Jack, any thoughts on pediatric first year of life versus later?
Yeah, well, those who are affected as infants, the severity of the illness seems to be greater than at other ages, and their survival is lower. We know that for both myocarditis and cardiomyopathy if you're diagnosed as a newborn or infant. But you're right, we do see those two spikes: infancy, the first year of life, and then once again around puberty. And those are not only are those the most frequent people who are affected, but they also seem to be the sickest as well. The good news about the older kids is that frequently they have recovery of function. We support them, through the process, and we often end up with recovery of function, many of them to complete recovery.
Absolutely. I'll take a few, there are a few individual questions here I'm going to read and give short answers to, and maybe I'll do 3 in a row here. Does climate have an impact on myocarditis? And it's interesting, enteroviruses, which are waterborne viruses, tend to be more common when the water is not frozen in Minnesota. So in the northern areas, there is a higher rate of the enteroviruses when in temperate months. But on the other hand, influenza, which comes out in October, and the season is in the winter, when you're in closed areas, and can cause myocarditis, seems to have a winter pattern in there. There are regions of the world that have specific pathogens, like Central and Northern South America, like Colombia, Bogota, where you can get Chagas disease, which is from a certain bug, and protozoa, which is very regional, and it depends on the climate as well. But in general, it depends on what virus is circulating as opposed to temperature alone. Are there any foods that you should avoid? Just maintain a healthy diet for general health, not specifically myocarditis. And what about weight? Is weight a risk factor for myocarditis? And the answer is I don't believe it's ever been studied, obesity and myocarditis. Certainly in peripartum cardiomyopathy, obesity is a risk. But I don't think I know that for myocarditis. Jack, obesity?
Yeah, it's interesting, with COVID right now, that patients who are obese are more likely to be most severely affected when they acquire the infection. I don't know if subgroups have been analyzed about those who develop myocarditis, the obese patients versus the non-obese. But it is interesting that obese patients are more likely to be more seriously affected with COVID-19 than others.
In general, it's not good to be obese, right? So cancer risk, some studies suggest Alzheimer's, hypertension, diabetes. There are lots of reasons to have an optimal body weight. And so even if it wasn't true specifically for myocarditis, I would recommend a healthy lifestyle. There are a couple more questions on exercise, which I think we covered. I agree completely with what you said. 6 months is the European guideline for people with pretty bad myocarditis, systolic dysfunction of the heart. We do recommend 6 months, but some very mild cases can be 3 months. The one thing about exercise we didn't talk about is the other side, that there's some people who get very fearful of exercise. And I've had some younger patients in their teens who got myocarditis, got better, and then were afraid to go back to exercise because of the fear of sudden death or recurrence. And I don't believe there is a high risk after you've recovered. And so I want to emphasize for this group that our guideline is to avoid competitive sports, quote unquote, which would be singles tennis or NCAA level 1 sports, for sure, when you're acutely infected. But normal activities, walking, getting showered, getting dressed, going on a level bicycle ride, not at high effort, those are not competitive sports. And so you don't want to become fearful because that can be just as debilitating. And over many, many years, sedentary lifestyle is a risk for cardiovascular disease. So there's another side to that coin, that occasionally you get fearful, and we don't want people to be frightened of normal life. So Jack,
I have a question here.
Yeah, go for it.
I have a question here, Les. This is a question that maybe both of us can answer. The question is the use of a low-dose beta blocker a common recommendation for patients who have some persistent late gadolinium enhancement in the inferolateral LV wall that is subepicardial with no known rhythm issues? This sounds like a healthcare person asking this question with all these terms. I guess the question is, in patients who have some degree of injury on a cardiac MRI, should they be treated with a low-dose beta blocker, even though they don't have any kind of abnormal heart rhythm issues? Well, that's a good question, and I think a lot probably has to do with this particular patient and the treating physician here. I'm guessing that this physician may be concerned about more than just the findings on the MRI, but maybe not. Maybe this physician is concerned about how this patient presented, the severity of the illness, whether or not there were some irregular heartbeats during the initial phase, what the heart function now looks like. So I think there's a lot of nuance to this question. Beta blockade, this is a standard heart failure therapy in patients who have depressed cardiac function. It's also a standard therapy for patients who have dangerous or potentially dangerous heart rhythms. So it's not unreasonable to use it in those situations. But this question is specifically about patients with no rhythm problems, but evidence of injury. And I wouldn't necessarily do it just for that reason. That's just me. But I think there's probably a lot of nuance and other details related to this question that would go into my decision making. Les, what do you think?
I think it's a great question, and for the general group, let me explain that what they're describing is a low risk scenario. So again, I'll extrapolate a little bit that this is somebody who had normal heart function and had a pattern of scar or delayed enhancement, which can also be inflammation. in the heart that was low risk. That infralateral epicardial pattern has about a 1% per year rate or less of major adverse events in both the Italian and the US MRI series. And so the overall framework is this is a low risk person. Then the second part of it is what in that setting can you lower the risk of any clinically meaningful events, which could be arrhythmias or symptoms of palpitations or maybe heart failure in the long run by giving a drug when your baseline risk is only 1% per year? The answer is there are no studies. We don't have any clinical prospective or registry studies in people to say that a beta blocker specifically would lower event rates. But we do have animal studies. So we know that in a couple of papers in mice who had a very, a model form of myocarditis that was a lot more severe than what you would get in a typical human infection, that carvedilol, which is a kind of beta blocker, improved inflammation and outcome. Interestingly, another beta blocker called metoprolol did not do that. So it's not a class effect, it may be drug specific. And then the second thing is that if, as you were saying, Jack, if this person had palpitations or extra beats that were causing that, you could treat those with a beta blocker to improve symptoms. But the short answer is we don't have a clinical guideline or any clinical high quality data to say that a beta blocker would change a clinical outcome like an arrhythmia or heart failure in the future in that setting. It could be done on mechanistic reasons. It has been done. It's not, I wouldn't say it's contraindicated. It's just not, there's no clinical guidance in that regard. Great question.
Yeah.
The point, how many gaps we have in our knowledge, right?
Yeah, absolutely. Okay, here's another pediatric question. Some health, or at least it's listed in the pediatric section, some healthcare clinics do not have imaging or a lab within their building when a patient is seen. What would you say would be the ideal tools or settings to help diagnose myocarditis when a patient is first evaluated? Ideal tools, I think we have to go old school here, and I think an ideal tool is a good physical exam and a good history. Those are critical, I think, in trying to tease out someone who comes in with symptoms that maybe not be clear-cut for meeting a diagnosis of one thing or another. But a good history is imperative. At least on the pediatric side, it's not uncommon for us to have a teenager who presents with giving us a history of, 2 weeks ago I had a bad infection, viral infection. It was like a really bad cold. I got over it, but now I'm feeling sick again, and I'm fatigued and short of breath, and that sort of scenario. That's not uncommon to have what we call a viral prodrome, or a history of a viral infection preceding their coming to our attention. So good history is important. A good physical exam, likewise, is also very important. We kind of alluded to this earlier. You can't just quickly bypass things like the cardiac exam and even examination of the belly. There are certain clues when you perform a cardiac exam that can lead you one way or the other. How if the heartbeat is regular or irregular, if there's an extra heart tone that you can hear on your auscultation or listening, if the liver span feels like it's enlarged or not, or if it feels like there's extra fluid within the abdomen. Those are some very basic and important features that you can pick up on a physical exam at the bedside very quickly. In addition to that, some basic fundamental tools that can help you go down the pathway would be a chest x-ray or an EKG. An EKG in particular, I think, can give you some clues as to cardiac involvement in patients. And then, as you move down the pathway and your diagnosis list kind of becomes smaller and smaller, you can do additional testing, things like blood tests, for example. A test that we use commonly when we're suspicious of cardiac involvement is the Bnp test, B-type natriuretic peptide. This is a hormone that's commonly released in situations of heart failure or volume load on the heart, pressure load on the heart. And so when that's abnormal, especially in children, that's a clue that something is up on the cardiovascular side and deserves further investigation. And then beyond that, more specifically, when you're clued in on the heart, an echocardiogram will be important to help when you assess heart function. So those are some of the fundamental tools and basic tools, and you don't have to be in a fancy hospital to be able to do a good physical exam and a good history, or even to be able to get an EKG that can start to lead you down a pathway where if you need to transfer a patient to another facility who can care for patients who are a little bit more complex, then it can make it, you can expedite that. So that's how I would approach that. Les, what do you think?
I agree completely that if you're thinking of myocarditis, a good physical examination to listen for early signs of stiffening of the heart or increased pressures in the lungs or fluid that's retained in the belly or the legs, those are easy to do. A good exam will help you immensely. A simple test like an EKG has powerful prognostic value, as well as things like a chest X-ray or simple blood test. So you don't need an MRI or a biopsy available initially to get to fall into a higher or lower risk category. And then, because it's only a point in time in the clinic, to have good follow-up, to make sure that if things clinically deteriorate, that the patient is able to come back expediently. Before you get off the line, I know we have for a few more minutes, Jack. I wanted to cover a post-transplant and a mechanical circulatory question. I would say that we have one of the people on the call who asked another question about PVCs and palpitations and beta blockers. I'll just very quickly say the question was for extra beats that are bothersome, called premature ventricular beats, treated with a beta blocker. In this case, it was metoprolol. Are there any alternatives if you're having side effects or not tolerating it? And the short answer is that it's definitely something to talk about with your doctor. In general, not specifically for you, there are alternate beta blockers which you might tolerate better. For example, we mentioned carvedilol or bisoprolol, which might have a different side effect profile compared to propranolol and metoprolol. And the diltiazem or verapamil are calcium channel blockers. Sometimes there are ventricular arrhythmias that are calcium channel blocker sensitive. And those are not the most common, but they do, in those settings, you can have a really nice response to a medicine that has a very different set of side effects. So that's a general answer for the PVC question. Then let's go on for Jack and for me. There are a couple of questions about mechanical circulatory support and transplant. The first is, I'll read it. So what is the typical ejection fraction level required to remove a ventricular assist device? When having an echocardiogram, how much of the ejection fraction on the scan is augmented by the ventricular assist device? Very specific questions. You want?
Yeah, those are very specific. We don't necessarily have a cutoff number of an ejection fraction, and this varies from center to center too. I think this hasn't been fully protocolized, and it's not a standardized way, across the country. So there's a lot of center variability in how this is done for weaning patients off that. And first of all, it's uncommon to come off a durable long-term device. Those are rare situations. The patients who are most likely to come off are younger patients. So we have seen that on the pediatric side. We've had, probably a half dozen patients who have been supported long-term and then who have come off. And we typically will take those patients to the catheterization lab and measure their hemodynamics as we wean the VAD support or the flow of the VAD device, just to see how well the heart begins to compensate as we provide less and less support. And so, I think a lot of variables go into this, not just the ejection fraction, but what's happening to the hemodynamics as we wean down. We don't, unfortunately, we don't see it very often where we're able to take someone off a long-term device. I think probably in those situations where we have, it's been in situations where patients had something that's potentially recoverable, like a viral infection or sepsis or chemotherapy-induced cardiomyopathy. We've seen that a couple of times. But I will also give this caveat that we have removed that support in a few patients, and it hasn't always worked out well for our patients, even though we saw encouraging early signs that it would work out. And so we even had a patient who had to go back on a device, a second device. So it happens in very few situations, and it varies from center to center about how you approach that.
Absolutely, I'd agree with everything you said. That it's really complicated. Certainly for durable devices like the HeartMate 3, it's unusual to come off. There is a group of people with very acute and fulminant myocarditis who are on things that are temporary, like there's a device called an Impella that we use in adults, balloon pumps, and there are different forms of ECMO, which is a kind of heart-lung bypass circuit you can use. And people can be weaned. In fact, we have a patient I was just taken care of who got weaned off of ECMO with fulminant giant cell myocarditis. So it does happen, and but there's an art to it, right? Because there's the left ventricle as well as the right ventricle, and you have to make sure both are working, and that the other systems, the lungs, for example, are working well. So the last question is a transplant question, Jack. Before you have to go, and that's the question is, following transplant, this person who wrote in was having fatigue and headaches. Where to go? And the question was, how often do you see this as a consequence of post-transplant medication, or fatigue and migraine headaches, or does this require more specific evaluation? It says, could these be from anti-rejection meds? Is the way the question is phrased.
Mm-hmm. We don't see a lot of fatigue, after transplant. That's one of the benefits of doing the transplant, is you're able to be relieved of your fatigue that existed because of your heart failure. But fatigue probably is a result of something else that's going on, and could be a result of migraines. Headaches are they don't happen a lot in our patients, but it is a known side effect, and it can be pretty debilitating for some people. There's a lot of variability there, and those drugs that we use, the immunosuppressive agents, some of them are known to cause headaches. So kind of like what we were talking about with the beta blocker before, I guess I would recommend talking with your transplant physician about this and seeing if there are other options. We know that you can have a drugs that are in the same family and act essentially the same way, that have different side effect profiles. So it's possible to maybe switch that medication to a different one in the same family that provides the same immunologic benefit, but has a slightly different side effect profile. We've done that in some of our patients. Sometimes what we've had to do is, so for example, a medicine called Tacrolimus, it's known to cause headaches in some patients, and other side effects. So sometimes what we've had to do is lower the dose, lower our goal target for a therapeutic level, and add in a second agent. So doing like a combination therapy. We've done that before for patients to try to minimize the side effects. So I guess I would definitely talk with your physician more about this, see what options are available, and sorry to hear that. That's a bummer.
So Jack, depending on how much time you have, it's 11 here, 10 or 9 where you are, and I we have 2 more groups of questions. On lymphocytic myocarditis, we have several questions again on diagnostic methods and some treatment questions, and then we have about 8 questions on giant cell myocarditis.
Yeah, I probably need to break away here. I'm sorry about that. I've got to join my team on patient rounds in the ICU, but it's been a pleasure participating today, and I hope we've been able to answer some questions that have been on people's minds. And I want to give a shout out to Karen doing the exercises. That's awesome, and she's putting me to shame.
We all should be doing that, Karen.
All right, bye-bye.
Jack, thank you so much. Have a great day. Good luck with the round.
All right,
Take care.
You too. Bye-bye.
Jen, we're at the halfway point here. We've got 30 to 35 people involved. Are there any updates or announcements you want to make for the group before we move into the next section?
No, we did have another question come in, had to do with, where to go?
Is it the one from 10:05 on the chat to everyone?
Yes, but I think you addressed that, didn't you?
So there's a specific question you can all see on your chat from Mr. Arroyo. It says, can there be a delay between COVID and myocarditis of 6 months? And the short answer is probably not. The COVID virus itself can hang around for a month or so, which is unusual. That's longer than a lot of other cardiotropic viruses. But 6 months would be a very long time. It would be exceptional. So I don't think that you would be able to link the specific COVID infection to myocarditis directly, in that if there was a 6-month delay. It's more likely that it would be a different virus, one in the community. That actually leads on to the first of a series of questions here about how to make diagnoses. And one of them is, the first question I'll address is on diagnosing viruses. This comes from Mr. Lodarchuk. And it says, is there a way to find exactly what virus caused the myocarditis? I have, and it goes on about non-invasive testing available in Boston that's not approved yet. And then there's some other questions. But with respect to the virus, the answer is yes, that we do have both polymerase chain reaction, PCR, and next generation sequencing available for viral genomes for both the RNA and the DNA viruses that are common. So that is possible. We do that in settings where we think it's going to change management. And those, we are those people who have pretty bad heart failure, who have a need for a biopsy to begin with. So for example, our current US guidelines recommend that we use biopsy for people who have fulminant myocarditis, the people who have heart failure in the setting of myocarditis with a need for mechanical circulatory support or intravenous medicines to support blood pressure. Or in that acute setting, people who have sustained or symptomatic arrhythmias from the lower chambers, ventricular arrhythmias, or where the conduction system fails, complete heart block. Those are the major indications. There's some people who continue to get worse despite guideline-directed therapy. After a couple of weeks in that acute setting, we also recommend a heart biopsy. Most people with myocarditis are not in that category. Maybe 85–90% do pretty well, and they have no substantial decrease in heart function. It may have a chest pain syndrome, and acutely they do pretty well and can be diagnosed by MRI. And we do have a recommendation that MRI is probably helpful in that setting with the right sequences. I would add that not all centers do cardiac-specific MRI. It's a set of imaging sequences that requires certain packages from the vendor and a certain level of expertise in the reader. So it's important to get an MRI at a center that has experience doing cardiac-specific myocarditis studies. So that's the question about viruses. we're going to go on. Actually, the same person asked about supplements. Are there any supplements? Actually, there are two questions. There's another reader or a person on the call who asked about a list of specific supplements over here. And the short and then there's a general question we touched on earlier about foods. And the basic answer is there are no supplements that have been proven to help myocarditis. There was a paper from Japan on seaweed extract. I forget the trade name of it that came out maybe 5 years ago, 6 years ago in animal studies that was positive for treating myocarditis. That's a kind of supplement. But no, there's no specific supplements that have been shown to help like garlic or coenzyme Q. Just looking through, there are a lot of questions. We'll go on to blood tests. Just to repeat, there's several questions on blood tests, and it's the non-specific markers of heart failure, the NT-proBNP, the BNP, and the markers of myocardial injury, like a troponin, which are the basis of suspecting myocarditis. We don't have a confirmatory test from the blood at this point. And then with the higher level of suspicion, you would go on either to MRI and or biopsy, depending on the clinical scenario. So I'm just going to finish up lymphocytic myocarditis before we go on to giant cell. Somebody wrote in about POTS syndrome. Could myocarditis as an autoimmune disease be associated with other autoimmune diseases, such as POTS in this case? The short answer is that giant cell myocarditis is associated with other autoimmune diseases, such as thyroid inflammation, thyroiditis, or inflammatory bowel disease, ulcerative colitis, or Crohn's disease in 20% of cases. The rate in non-giant cell or routine lymphocytic myocarditis is pretty low. It's well below that, but not zero. There is a small group of people who have connective tissue diseases like lupus or rheumatoid arthritis who develop myocarditis in the course of their disease. And that is, that's an important but relatively uncommon group that does get treated usually with immunosuppressive therapy. There's one other thing that's relevant to your question, which is there's one virus, parvovirus B19, that affects endothelial cells, and that can cause both chest pain from coronary spasm or endothelial dysfunction, as well as some peripheral vascular manifestations. I have not heard of POTS syndrome specifically, but there might be a connection in that one specific setting that has not yet been reported. I think we got all the myocarditis questions. If I forgot any, just please put it through the chat and we can answer those. But I'm going to move on to giant cell myocarditis. We have 8 giant cell questions, and I'm going to organize them right now over here. So the first is about, there are quite a few about transplant and recurrences following transplant in giant cell myocarditis or in the native heart. And let's start with that. So number one, in giant cell myocarditis is different than lymphocytic myocarditis because it is almost invariably autoimmune, not related to an infection. And it responds specifically to immunosuppressive therapy, usually directed at T cells like Tacrolimus or cyclosporin would be the foundation of therapy with other medicines. And that's true for both acute de novo giant cell and recurrent giant cell. The risk in the native heart, once you've recovered from giant cell, of having another episode of biopsy-proven giant cell is about 12.5% in our experience. And that risk extends out to 9 years following the initial episode. That's the longest time that in our experience we had biopsy-proven recurrent giant cell. The treatment, one of the questions here for native giant cell is there anything new in treatment? And yes, there is. So since 1997, when we published the cyclosporin-based treatment algorithm, a couple of things have happened. The first is Tacrolimus, which is generally associated with a bit better side effect profile, has become available. It was not available in the late 90s, and that has, in the transplant population, to a large extent replaced cyclosporin, not completely. And so in native giant cell, people are using Tacrolimus more. It's another calcineurin inhibitor, same class of drugs. That's the first change. The second is the antibody, the monoclonal antibody we used in the late 90s and early 2000s called OKT3. The trade name was Muromonab CD3, or that was the generic name, I mean. That is no longer available. And so that's been replaced with either anti-thymocyte globulin or another medicine called Campath, which is a different antibody against CD52, Campath. So that those are now our current antibodies that we use in some people with acute giant cell, and we have used in the post-transplant setting as well for recurrence. So that's the question about new drugs and the recurrence rate in the native heart. The next question is, please discuss how many people have had giant cell myocarditis, and are there any updates or breakthroughs in new medicines? We covered new medicines. How many people? There are probably between 300 and 350 people in the world who have ever had giant cell myocarditis since it was first described in 1905. There were about 90 cases up until 1993, and since 1993, there have been another between 200 and 300 cases. We hear of about one new case a month. Then the second question is, what is the long-term prognosis for giant cell myocarditis? Do we have statistics about recurrences? Recurrence in the native heart is about, again, 12%, and the recurrence overall in the transplanted heart is 20%, approximately 20 to 25%. The shortest time to recurrence is 16 days. The next shortest is 21 days, and then it goes out to 8 years was the longest. The prognosis is very good. So in native giant cell, prior to multi-drug immunosuppressive therapy, there was a 100% rate of death or transplant. There's currently a 70% or so, 77% rate of transplant-free survival at 1 year, and a 90% overall 1-year survival in our series, and it's similar in the series from Finland, which is the other large series describing the national experience there. The post-transplant outcomes are virtually identical to other causes of transplant, non-ischemic cardiomyopathy transplant, with excellent 1 and 5-year survival rates. Those were published about 3 years ago from the UNOS database. There may be a little bit higher rate of rejection in that database in giant cell compared to other causes of myocarditis or cardiomyopathy and transplant. And that was also reported by Charlie Cantor in the pediatric transplant literature, that children who are transplanted for myocarditis may have a higher rate of rejection than children who are transplanted for other non-ischemic causes. So, but even though you get more rejection in giant cell, that could include recurrence, I think, the overall outcomes are excellent. So we're now up to post-transplant. That covered 5 of the questions. And if you have any, just type them in the chat room if you have additional questions on that. I'd say one other thing, we haven't published this, but it's in press yet. In patients who are supported with a ventricular assist device for giant cell myocarditis prior to transplant, the post-transplant outcomes were better if they had immunosuppression given before or in association with the ventricular assist device. That's interesting because we also, that's a paper that we have in press right now. It's interesting because almost 20 years ago, we published the ventricular assist device experience with giant cell for the first time. And that showed that the only predictor of post-transplant recurrence was the use of a VAD or balloon pump before transplant. So in this case, the addition of immunosuppression to mechanical circulatory support seemed to improve outcome. So that's a new paper that should hopefully be published in a couple months. See everybody's face there. Type in some questions. There you go. So everyone can read this. I'll read it out loud. I compete in the sports of obstacle course racing and triathlons and was diagnosed with myocarditis back in March. That's about 7 months ago. Would it be okay to go back to such a competitive sport after a year of my diagnosis if a second MRI showed no signs of myocarditis left? Or should I never go back? So no, we do not, in people who have recovered from myocarditis and have no symptoms of arrhythmia and no heart failure, we do say you can go back. You can go back to competitive sports. The second issue is, what about the MRI? So we know MRI is incredibly useful to diagnose myocarditis, and it has some prognostic value depending on the pattern of delayed enhancement or scar and the changes in that pattern over time. But I don't think we have any guidelines at this point to preclude people from sports based upon an MRI. The one possibility would be if the area of delayed enhancement got greater, if it was increasing at 6 months, you might not want to do competitive sports. But again, that's conjecture. It's not in any guideline. The second question is from Kristen Hill to everyone. Just to clarify, people with autoimmune disorders have a high risk for GCM. So no. So there are lots of people who have autoimmune disorders like thyroiditis or inflammatory bowel disease, but there are only 1 in maybe 10 million people would ever get giant cell myocarditis. And so the rate of giant cell is so incredibly small that you would not be able to pick up any signal of association with the much, much larger population of people with autoimmune disease. What is true is that in people who present with acute myocarditis, 1% will have giant cell overall by biopsy, and in that 1%, 20% will be associated with an underlying inflammatory disorder such as thyroiditis. So in the giant cell patients who present, there's a higher rate of inflammatory disease, systemic diseases, but the opposite, is there a higher rate of giant cell in thymomas or ulcerative colitis? No, the answer is it's such an incredibly rare disease that we've never shown that association. Here's another question from Kyle Hansen to everyone. I'm a GCM survivor, but I'm now having all sorts of joint pain. What doctor should I seek? I'm meeting with a RA, I assume rheumatologist, but I don't have markers. Maybe who should I see? Well, a rheumatologist would be the person to see for joint pains, and I would work with rheumatology since it may or may not be bone specific. There are many possibilities that would not be specifically related to giant cell myocarditis. Again, for everybody, we're not giving specific advice for individuals, more general advice. This is a question from Yadira Tellez. Even though COVID has brought attention to myocarditis, do you think the pandemic has affected the ability to diagnose a patient with myocarditis when they are seen? Interesting question. I think there's a much higher awareness of myocarditis today than there was a year ago. So I think that because of that awareness, the diagnosis is made more frequently, appropriately. I think that gets to the answer to your question. From Carol Loderchak, is there a biotechnical way to regenerate heart tissue? Will scar tissue always be there? Great question. So there's a lot of regenerative medicine working on regenerating heart tissue from stem cells. There's a trial up in Rochester at Mayo using exosomes for people with acute heart attacks. There's a lot of work being done. As of today, there's nothing that's clinically available, and I would encourage people to be part of clinical trials where they would be candidates rather than to try and get a therapy that's unproven or not well tested. The next question from Haley Yu: what tests can be used to differentiate between a diagnosis of giant cell versus lymphocytic myocarditis? Actually, the only test is a heart biopsy. So we don't have any non-invasive tests. The relatively young age, otherwise healthy individuals, the association of other autoimmune diseases, the presence of malignant arrhythmias or heart block all raise the possibility of giant cell, but the confirmation of that suspicion is by heart biopsy. From Kyle Hansen: do you know of a giant cell myocarditis patient getting COVID? Are we more at risk? Great question. I do not. I don't know of any giant cell patients who have gotten COVID. And are you at more risk? I think that everybody who's immunosuppressed on chronic immunosuppression has a risk of more severe COVID if you get COVID, but it's not, I think the actual risk of catching it is not clearly elevated. Everybody, including giant cell patients, should wear masks, and I have mine right here. Wear masks, wash hands frequently, and practice social distancing. From Scott Stevens: 1 year following transplant for giant cell, biopsies are stopping after my annual checkup, and frequency for transplant follow-up is dropping. With how quick GCM comes on, what diagnostic steps are used for recurrence once biopsy ceased? Good question, because I think that in the pre-transplant setting, certainly we don't routinely biopsy, but we do follow people by echo and by blood tests to look for NT-proBNP, in addition to good clinical evaluation, symptoms and exam. And I think the same is probably true in the post-transplant setting after a point, with a very low threshold for biopsy. If there's an unexplained rise in the biomarkers of heart wall stress or injury without a clear reason, then I do think it's important to have a low threshold for biopsy. But the surveillance biopsies for people who are completely asymptomatic with normal heart function may not be needed. We don't know about other non-invasive blood tests at this point, specifically for giant cell. The next question comes from George Estevez. For someone who had late gadolinium enhancement in their cardiac MRI, but did not have a confirmed diagnosis of myocarditis from their cardiologist, would a loop recorder be good to detect myocarditis? And no, loop recorders are very good for arrhythmias, right? So you can, and again, this is I'm answering this in a general way, not specifically for you, but in general, loop recorders are great if you have infrequent and severe arrhythmias, but they wouldn't be specific for heart inflammation. So that would not be a reason. Again, I can't comment specifically on your MRI, but if there's a concern about myocarditis, I'd bring it up with your cardiologist, and in the context of what is now a pretty robust literature on the use of MRI for the diagnosis of not so severe myocarditis. Looking at everyone's face, it looks like people are pretty engaged. show of hands, is this going well for you guys? You like this? Good, good. Few people I recognize out there too. Hi, if you know me personally, I say hi to you. If this is really going well for you, we'll do this more often, right? We can, as a foundation, I'm happy to do this, Jen, every couple months, we can put on something like this. And we have other cardiologists too, with great perspectives, Bettina Heidecker on our medical advisory board, Dennis McNamara, others who are just terrific experts in myocarditis, who I think in their realm would be pretty useful. And so please give Jen feedback, okay? Jen and Joe, say what was good about this and what you'd like to see in the future. Now we have a few more questions that have come in from Linda Eckstein. For giant cell myocarditis patients, I've created a Facebook group. Oh, you can read that. Facebook group. Please consider joining for support. Terrific.
I really thank everyone for joining us today. This is the only option we have for doing meetings. And I think other than doing the actual face-to-face talking with other families that have gone through this, which we have found to be very, very helpful for people just starting out on this journey, being either a survivor or having lost someone, this is our only option right now. If you need to speak to someone though, I have contacts, other survivors or other people who have lost family members that have offered to speak to people. So if you really want to speak to someone about something specific to your situation, please give me shoot me an email. That's the best way. Jen, G-E-N, at Myocarditis Foundation. I'll always be able to respond back to you. The office phone, unless I'm in the office, I don't get those messages. So it's better if you email me. I will put you in contact with someone so that you can speak to them. But I'm happy to see so many people joining us today. And I thank Dr. Cooper and Dr. Price for their time. I don't know if you have any other questions, but if you don't, I think we're going to free up. What is this? Thank you for setting this up. Oh, you were very welcome. Okay. I think everything else Dr. Kristen Karasek, have you or the research found that myocarditis is always linked with autoimmune disorders or sensitivities?
Couple more questions.
The answer is no. So the vast majority of myocarditis in North America and Europe is going to be viral. It's going to be not linked to specific autoimmune disorders either before or after the diagnosis. There is in the small group of people who have autoimmune conditions like rheumatoid arthritis or lupus, by the way, those people actually have a higher risk of long-term atherosclerosis, just heart attacks, plain old heart attacks, and are more common, and blood clotting troubles in lupus than myocarditis specifically, but they do also get myocarditis. There's again environmental reactions, hypersensitivity reactions to drugs, and some things in the environment which are very specific, one-off diseases, disorders, which are very important, but they're really, really uncommon. In the ocean of myocarditis, they're just a tiny, under 10% fraction. And then from Tim Pineda, does a recurrent myocarditis 3 times in less than 3 years have any significant connection to autoimmune disease or versus just recurrent myocarditis? So this is where we're doing that research on desmosomal genes. And we have this paper, actually, it's interesting. It's, oopsie. There we go. Yeah, there's actually a paper right here I'm editing this morning, as soon as we get off this call, called The Ventricular Arrhythmias in Recurrent Myocarditis in Patients with Desmosomal Gene Variants. So we're hoping to submit this to a journal on Monday. But so we're actually working specifically on that exact question, but it's mainly a small group of people who have families or they themselves have recurrent myocarditis, and we found this high rate of these specific desmosomal genes, which are, again, we're not the only group. There are about 6 other papers in this area, but that's a small fraction. But that would be what I'd say, that it's leaning more toward being an indicator of a genetic predisposition. Okay. And from Teresa about fatigue, again, there are multiple reasons for long-term symptoms and that are independent of heart function or lung function. And in your specific case, it's hard to comment, but I would definitely work with your physicians to identify the underlying mechanism and a good treatment strategy. Well, it's great to see everyone. Thank you so much. Please give us your feedback and we'll do it again.
Thank you very much, Dr. Cooper. And thank you, everybody. Enjoy the rest of your day. And we'll let you know when the next meeting will be. Take care now. Bye-bye.